Welcome to the Parenting at Mealtime and Playtime Quality Improvement Project and our first webinar, Laying the Foundation for Improvement, and we hope that this helps create a climate and foster change within your clinical setting. We have a couple of items that we'll be addressing throughout the course of this webinar, the first of which is really looking at your core quality improvement team and who would be on that, understanding your roles and responsibilities with respect to this project. We will go over the project objectives again and cover how those relate to the project aim and what we hope you'll accomplish over the course of the coming months. And finally, we'll look a bit at your pre-work and the items that'll help you address clinical gaps that you would like to close, where you're currently at, and our opportunities for change that we can address throughout the course of the coming months. So I like to start each of my quality improvement initiatives by bringing to the forefront what our global or project goal is. And I really think this is helpful to help you hone the vision for everyone that's working on this project so that we're all orientated to the same task or purpose. And the global aim for this project is to achieve optimal health for and prevention of overweight in young children through early identification of risks at all our well child visits. And this will be specifically for those well child visits birth through 5 years of age. And with our vision honed to what we hope to accomplish after all of this is said and done, that global aim is depicted on the bottom left-hand corner of your screen. Directly above that are specific items that we'll work on over the course of the coming months. Likely around 6 to 7 months' time, you and your practice will work to improve the delivery of anticipatory guidance and identification of obesity-related risks at those well child visits birth through 5 years of age. And we hope that this helps you measurably improve the behavioral health of those infants and young children. There are 4 specific aims or items that will help you work on and impact through a series of changes and interventions, building on some systems and processes and things that you may already have in place, layering in elements to help you get up to the goals that we've set. The specific aims that we have for this project are to help you document obesity-related health risk in our well child visits birth through 5 years of age at least 95% of the time. And then we also want to help you in terms of your documentation around our PMP indicator questions, and doing so 80% of the time or more, again for those birth or 5 through 5 year old well child visits. I'll cover in a bit just what those indicator questions are. The third aim is looking at 75% of children who are overweight or obese have the provider discuss with them their growth curve. And then finally, for families that haven't identified risks from any of the areas that we'll be noting, 50% or more of those will set a goal. So how do we work to accomplish and get to those numerical targets that we've set within the specific aims? We have 3 key drivers, which are listed in the middle of the screen, providing age and developmentally appropriate preventative care and anticipatory guidance, of which we have 2 boxes of interventions that will help you impact that specific area. Listed within those boxes, we have things like providing PMP handouts and making sure family resources are accessible, formatting your medical record to support specific documentation of our specific aims. And then there are elements in that second intervention box that look more specifically at those measures of obesity-related health risk and your documentation of indicator questions, such as looking at height and weight, recording an appropriate weight for length or BMI percentile, and interpreting what that means for the child's weight status. That also ties into our second key driver of assessing risk for excess weight gain. And that second box under the intervention column really helps address elements that you can layer into what you're already doing to further supplement the counseling and risk assessment that you're providing for children birth through 5 years of age. The third and final key driver is to intervene when appropriate at the earliest point possible for obesity management. And that's what those final 2 boxes in the intervention column address. Helping you encourage a dialogue with families and caregivers, honing any motivational interviewing skill set that you have, building upon that, and integrating that even if it's just a minute's time within that well child visit. The purpose of this slide is to compartmentalize what elements you'll be working on over the coming months so you can see what will occur in a time series fashion. There are a series of items that you'll be completing that pertain to the key driver diagram from the previous slide that will help you get your MOC Part 4 credit. It'll be watching webinars, collecting and entering data for your data submission, and quality improvement strategies like PDSA worksheets and office flow and process mapping. We've broken down all those elements that you'll be completing into 7 modules, and the first of which, what we're currently doing now, is the pre-work phase. You'll come together with the individuals in your practice and determine who will be on your core quality improvement team, collect a series of charts that will comprise your baseline data, and inform where you currently are with respect to the PMP measures. Moving into Module 2, you can think of this as an e-learning session. The content that's specific to PMP, how we built the foundation for PMP, nutrition and play components will be addressed in Module 2, as well as some core quality improvement methodology. Modules 3 through 6 will be the action period, where you'll take the information and the quality improvement tools that you've learned about and work to improve certain processes, be it from the key driver diagrams, interventions, or specific plans that you and your clinical core quality improvement team had in mind, to move the needle to get you to those numerical targets we have listed on the specific aims for PMP. Collecting data, testing changes, and having feedback to work towards those targets. And then we wrap up with Module 7 with some more sustainable best practices, making a sustainability plan, and leaving you on the right foot for moving forward from the improvement phase to a sustainable phase. We will, however, throughout the modules that you'll be working on, have some sustainability elements noted, and they will be sprinkled in so that you can think about those with the context of improvement and then shift gears towards looking at how this can be a more sustainable process once the project wraps. We have hosted the Parenting at Mealtime and Playtime quality improvement work in a series of venues and a variety of ways. We've done it in person, online, solo provider, practice team, and what we've come to learn is that people are more successful in their improvement efforts when they have others supporting them and they work as this effort as a team. So if you decide to pursue this as a solo provider, you will be successful, but it's helpful to keep this in mind, the information on this and the coming slide, should as your work wrap that you would like to spread this work to other providers in your practice or your clinical setting. We hope that you will take the time to identify other people, providers, nursing staff, admin, front desk, who will assist you in testing changes for PMP during this collaborative learning time and support the implementation and sustainability of the improvements that you've made during the action period post-collaborative. Think about interprofessional team members, some of which I just mentioned, someone from the front desk, an office manager, other clinicians, nursing staff, it could be WIC, social worker, anyone that you feel is helpful to your nutrition and play endeavors with respect to PMP. While we encourage the team approach, we also think it's really important to have a champion. Most of the time, this is a physician and they tend to be the day-to-day contact, but this can also be a nurse practitioner, the office manager, someone that is going to spearhead this, have time and resources to allocate towards rallying everyone up, bolstering them, supporting them, and helping with the improvement journey. It's also helpful to have someone with technical expertise, be it clinical, and the knowledge that is around nutrition and play, or it could be someone that has IT experience and may be helpful in some of the new elements that we'll be working on in terms of documentation. Someone may be able to make dot phrases or smart phrases within your electronic medical record, and they may be helpful to bring to this team. And then finally, just even talking about this project with the senior leader or sponsor to get them on board from the beginning, let them watch the improvement journey, the improvements and changes that you're going to make, and the impact that it has on you as clinicians, but the families most importantly, so that when this wraps, you have their buy-in and they've seen the progress and they can help you spread this effort to whatever venue is next. This slide just reiterates and looks at some of those elements that I listed on the previous slide with respect to the core people on the improvement team, having that leader or system authority with time and resources, the day-to-day contact who can help rally everyone around the changes and processes that will help you bolster within PMP curriculum. Clinical and technical expertise, again, subject matter or IT or expertise that could help supplement what you're going to be doing in terms of your counseling and risk assessment. And then that day-to-day contact or leader who's going to really drive this project, help the different pieces come together, and make sure that data is collected, you have feedback, it's submitted to our project manager, all the different workings that need to be managed throughout the course of this project. As I mentioned on the bird's eye overview of the time series progression we'll work through over the coming months, I'm going to layer in some sustainability factors that have been researched and are found in the literature to help a quality improvement project spread and be sustained post-collaborative environment. And here's the first of them, leadership. So we've mentioned how to have a core quality improvement team. The previous slide just noted that leadership component, that its importance. So one key to success is having a leader who can combine those clinical and technical QI skills with their interpersonal and relational skills. So they not only have the subject matter, but they know how to work with people, that psychological component that can figure out what people's values and attitudes and beliefs are, as well as their skill set. But then they can also be there not only at the physician level or the nursing level or the front staff level, but come across all of those levels. So we're not necessarily in our silos, but spread across vertically and horizontally to help drive the improvement effort and change for PMP within your practice. Another one of those following up are some of those components that we can use with leadership to really foster and connect on the 5 planes of engagement. Social really looks at building on the energy of your personal relationships and connections. Spiritual is the value of the work and inspiration. Why does this project matter to you and to those that are involved? What is that piece that you can help get to have their buy-in on why this is a valuable process for them? Psychological is the courage and trust and feeling safe to voice their opinions, to give feedback on what they think may be working or not working. So being able to have that open dialogue and discourse about the efforts that you're making. Physical works with the energy of action and making progress through your improvement journey. And intellectual is thinking about the evidence that you have collected, the information that we're presenting to you, and thinking reasonably about what works and what may not work within each of your specific clinical settings. And this is all really helpful to encourage your engagement, commitment, and motivation for this project. And this is something that may not just be something for the physician champion or the leader of the core QI team, but maybe someone within senior leadership can help foster and engage on these 5 planes. Engagement. This really is something that leaders should be able to know the crowd that they're working with, who's on your core quality improvement team, and to help build that culture. So we really want to engage individuals to make them feel that they are a part of the test of change and can help spread the ideas to align with everyone's thoughts and feelings and behaviors for all those stakeholders that are involved from the different vertical and horizontal planes within the clinical setting. Trying to understand where they're coming from, the way that they think, how they engage with patients, their different behaviors throughout the day, so that they feel a link between what matters to them and what matters to the organization. Connection is that first part, that linking between who they are as a provider or their part within the daily clinical flow and that practice or clinical hospital setting. Content refers to how the actual tasks people do are enjoyable to them and how it may challenge them. So figuring out what people's skill sets are and setting stretchable but achievable goals or components and roles and responsibilities that they can work on. Context is how far the way the organization operates and the physical environment in which people work make them feel that they are supported in their work efforts. And that culture or climate refers to the way that people and how we do things around here or encourages them to be their best. So leaders, it's helpful to always think about how you're connecting with the individuals on your team, reminding them why this work and the improvement around PMP is needed, and communicating with people and making them feel that they are part of this change effort and that it's not just another task added onto their plate, that their role is really instrumental to this process. Another factor found in the literature that really helps individuals and core quality improvement teams and quality improvement projects be successful is empowerment of the individuals that are working on this. The leadership or the champion may possess these skills, or may be someone else on the core quality improvement team or within the office that you really think of as your cheerleader. They hear you, they listen to you, they respond to your needs, to the patients and providers alike. So making sure that all those that are involved in this process that may have some extra work added onto their plate are feeling meaningfully involved, and that we're shaping and working with them to use their pre-existing skills and knowledge to kickstart their confidence and competency to perform new tasks related to PMP and its activities. And as you're working to shape the core quality improvement team during team meetings, and more importantly, as you're thinking about things, test of change and ways that you may attack something differently than you may have previously done, this is a way to help encourage individuals to come back with feedback and really feel autonomous in this effort. So you can think freely, report back to the group freely, and not feel that you are being judged for your comments or that it's a small thing that you may have done. So highlight how individuals can influence the collective improvement effort and what impact their role has towards achieving the short, intermediate, and long-term goals of this project and those of your practice. How does this all tie together and help empowerment in that effort? And then in creating this culture for empowerment, a deliberate effort should be made to really listen to everyone on the team, the patients impacted by this, so that as you're approaching your work with PMP, people are involved from the get-go. They bring their interested individuals into the fold when they see it appropriate, and they can listen to them when it comes time to decide where the improvement work is going to go, picking what items to test, actually testing them, and then working to evaluate the impact of these changes. The more that you as the lead physician or champion can do this, the more team members feel a sense of ownership, and the more likely they are to bring to your attention problems, to develop ideas to fix those, and harness energy to get the work done. We're going to be shifting gears a bit, and I hope the last couple of slides help paint a picture of why we support a teamwork approach, be it you and another individual, or if you can get everyone from your clinical setting or practice on board for this effort, the more the merrier, and it helps make it an improvement effort and culture of healthy habits for diet and activity within your practice. These next coming slides will be looking at what will we do to prepare pre-work wise. We will be holding a pre-work interview kind of discussion with you and the individuals from your core quality improvement team, if you go that route, to learn a little more about you as providers, the patient population you serve, and your unique clinical culture and context, so that moving into the coming months, we have a better understanding of what things look like within your practice, what barriers you may have, and what your clinical environment looks like, so we can fine-tune and adapt some of those interventions from the key driver diagram to meet the needs of that clinical context and culture, and make those changes specific to what you need at this time. The first step in doing this is looking at your baseline data. We need to understand where we're coming from and what gap exists between where you are and the aims we've set in the specific aims of the key driver diagram. We'll do this by capturing data in 2 cycles of data. Cycles are the term for the cluster of charts that you'll be pulling from a specified time frame. There are 7 total cycles. 2 of these will be for baseline, and 5 will come from that improvement, change, action period time. The cycles will consist of 12 charts, and you'll be aiming for 1 chart from each of the suggested well-child visit age ranges. You'll be collecting data from the listed months. This baseline data will be retrospective, coming from August and September of this year. And then you'll go to enter the data on our project homepage in the Quality Improvement Data Aggregator called QIDA. I'll say that moving forward because Quality Improvement Data Aggregator is a mouthful. So the elements that you'll be collecting are depicted here as screenshots of the chart review tool on this slide and on the coming slides. They correlate and correspond to the specific aims. So here we have risk assessment. It's comprised of the child's weight status, growth trajectory, blood pressure, and the family history of that child. After completing those first kind of demographic elements of the well-child visit age, who's attending the visit with the child, the month and year of the visit, as well as the child's gender, we'll move into the risk assessment portion. We've tried to make this tool be as user-friendly as possible. You can use it as a chart review tool alone to abstract information from the chart and put into QIDA. You can directly enter information from your medical record into QIDA, or you can use this tool as a decision support tool and use it with every well-child visit to remind you to do these steps with every patient birth through 5 years of age. Any three of those options are certainly okay. It's what works best for your clinical flow, what you like to do in terms of writing things down as a provider or how you document, and how you'd like to collect the data. So walking through these first four elements, weight status is simply looking at the weight for length or BMI percentile of that child, dependent on their age. You'll use one or the other. And then based on that weight for length or BMI percentile, quantifying or putting a term, weight status verbiage, for that child. Were they underweight, of healthy weight, overweight, or obese? And making sure that that verbiage is explicitly documented within your chart. Growth trajectory builds upon the weight status, so interpreting and assessing what that child's growth curve looks like and having a conversation about that with the parents. You're looking to see if you've had documentation of review of this child's growth curve and that conversation with the parents about the curve. Question 8 is assessing that pattern of growth trajectory. So you'll be looking at a series of visits on the growth curve, and since the last visit, has the child's weight for length or BMI percentile decreased, was maintained, or did it increase? And this is looking at a trend and not if they went up 1 or 2 percentages, but did they shift up a curve from 50% to 75% and having some sort of comment about that. Blood pressure are for our kiddos 3 years of age and older, and looking at if you had a blood pressure reading for that child and categorizing that blood pressure and having documentation of that blood pressure category verbiage. So were they a normal blood pressure, elevated, stage 1 or stage 2? And those criteria and percentiles for each of those categories are listed in that box within the blood pressure section. If you didn't obtain a blood pressure for that child, check the box on that left-hand column and skip to the coming question. The final component is on family history, and this looks at if the family history was collected and updated and having documentation of that. And if it was obesity-centric, did you perform and evaluate that child for obesity-centric conditions? Those items are highlighted in bold yellow text at the bottom of this section, and you can note any positive indication for those conditions. This next section looks at your counseling around diet and activity anticipatory guidance, and whether you had documentation for several elements. Age-specific diet anticipatory guidance for physical activity, if you identified through a review of their diet and activity habits an opportunity to improve a specific area, or if you had some sort of notation that other areas or issues became priority and you weren't able to discuss your traditional anticipatory guidance, you can select that fourth box. The final option is that you really didn't have any discussion around anticipatory guidance or items to improve, and you would opt to select that final box. The other component of this counseling around diet and activity is providing a PMP handout at this specific well-child visit, and you can note whether or not you had documentation of that, and if that handout was provided, what handout it was. Then you're going to digest the information from questions 1 through 14 to identify if any risks were noted in that child's chart to see if you should continue for review of other elements. Those risks are considered an unhealthy weight, be it underweight, overweight, or obesity status. If they had different trends or changes in their growth curve or trajectory where they crossed several percentiles and indicated a pattern or a trending in a growth area. A high blood pressure for those kids over the age of 3, any positive indications in their obesity-centric family history, or if you felt that the child did not have any optimal diet and or activity habits. Any of those elements would be an indication that you would move forward to the chart review of questions 15 through 19. If they didn't have any of those items, you would skip ahead. So we're going to move forward as if they had a positive indication of one of those risk factors to talk about the motivational interviewing and goals that should have been set in that child's chart. You may not have all of these elements in your baseline chart reviews, but these are items to consider moving forward during the action period. Question 15 looks at motivational interviewing and the techniques that you may have used during that visit. You do not need to have explicit documentation of I used a readiness ruler, or I asked open-ended questions, or used reflective questions. This is solely you just thinking about the encounter with the family and noting, yes, I used motivational interviewing techniques, or no, I did not. Moving forward, the next question is to decide how you'll answer the coming questions. Did the family set a goal? If they did, you'll move on to 17 and 18. If they did not, you will skip to question 19. And skipping is because the family declined to set one, you didn't have documentation of a goal being set, or you had documented that there were other priority items that you needed to discuss at this encounter and therefore did not have time to set a goal. Question 17 looks at what your discussion was and how you documented that conversation about setting a goal. Did you document a plan or advice about how this child could lower an identified risk or potentially modify a behavior or habit? Did you note a SMART goal? And it doesn't have to have all of these elements of specific, measurable, action-oriented, realistic, and time, but having some of those drawn to the patient's attention that we are working on this one specific item, and you're going to try and accomplish this by doing X, Y, and Z between now and your next visit, and having that conversation with the family. We'll have a more in-depth discussion about what a SMART goal is in Dr. Keely Pratt's webinars about using SMART goals for success. And Dr. Bowling also mentioned some of these skills around motivational interviewing and goal setting and how you have those conversations with families to help you as you improve your documentation in this area. Question 18 is simply check which of these topic areas pertain to the goal that you may have set with the family. Questions 15 through 18 are really just looking at your encounter for when a risk was identified and how you approached that risk with the family. 19 is separate. So this is a process that we're hoping you work to embed within your clinical flow to take just a moment's time to look back at the patient's prior well-child visit to see if they had set a goal at that previous visit. And based upon that goal, when you come into this current encounter or the current chart that you're looking at, did you talk to the family about the goal they set at the previous well-child visit? There are several options you can select here. You can select NA, the family declined setting a goal, or you didn't find documentation of goal being set at the previous well-child visit. Or you found a goal and the next boxes look at you talked about the family's progress on the goal since the last well-child visit. The family didn't report any progress on the goal since the last well-child visit. Or you took the next step and noted what were the next things that the family was going to continue working on with this current goal or in a new area. And the final element is I did not review the chart or follow up on a previously set goal. So we kind of have a way of teasing apart. You haven't yet gotten to improve this process of looking back in the chart for a goal versus there was no documentation or a goal being set from a prior encounter. The new element that we're adding to this iteration of the project are indicator questions, or these are target behaviors that are specific to PMP's innovative and unique nature. These were ones that our advisory committee thought were important that you should query to families, some are age specific, through the course of birth through 5 years of age to make sure that we're hitting on specific targets with these individuals to set them up for success in some of the conversations that you may have. One of them that is unique to PMP is fullness, and having cues being read by the child or you as the parent to help guide their feeding habits. Question 1, and these are listed on a separate sheet of paper, will pertain to fullness in newborn through 24 months, and then there's a mealtime fullness for those kids over the age of 2. And you can select the responses here that are pertinent to each. Question 2 looks at beverages and the consumption of any or all of these, and 3 looks at screen time and the amount of time that they have within the day. There are 2 columns of information here. You have the previous visit responses and what well-child visit that corresponds to, and the final right-hand column looks at the current visits response and the well-child visit age for that visit. There are a couple of things of logic to consider here. I'm going to start with the current visit. So you've been reviewing the chart for Johnny and have gone through the elements of risk assessment that you may or may not have documented, elements for counseling around diet and activity, and then whether or not you set a goal for that child. Looking at this current visit, we're going to work with you to set up some smart phrases or dot phrases to capture this information. So from the current visit, what was that child's response or caregiver's response around the fullness question, beverages, and screen time? And you'll indicate that response here. As we progress a little further into the collaborative and the quality improvement project, you'll then move to the left-hand column of previous visit. So after you've completed all the elements that you need for looking at that current chart, you'll go back to the most recent well-child visit. So if they were at their 2-year visit today, you would go back to the 18-month visit to look at this information and see what was recorded in terms of fullness, beverages, and screen time. There's some skip logic, as I mentioned. For that current visit, for all of these baseline charts for pre-work, you'll select skip this because we have not yet incorporated this into the chart. Moving forward, the previous visit, you'll select skip if this visit occurred before October 15th, again because we haven't yet implemented this, and also skip if this was the newborn visit or initial visit for the practice, because of course they're not going to have a visit response from a prior visit if this is the first time you're seeing that patient. We'll cover this and the specific questions at your in-person meetings and on future practice coaching calls, just to call that to your attention, but that's the methodology and logistics beyond collecting this information. If you do have any questions about what counts for documentation or what doesn't count, you can refer to the measures table. Again, we tried to make the chart review tool as a decision support tool, so everything was really intuitive. But if it's not, or if something's unclear, you can refer to this measures table, or you can talk to our program manager or myself to ask, does this count as documentation, or did I need something different? Moving forward, after you've kind of gone through and used that chart review tool to gather your baseline data, you'll enter it into KEDA. This is just a screenshot of the homepage for that, and you can see at the bottom of this the data collection tools, and there's a well-child visit chart review tool. It very much mirrors what you see in the chart review tool. So the responses you've taken and abstracted from the chart and put on the chart review tool, you'll place into the KEDA chart review tool online. This is being revised, so we will have a separate webinar that'll be about 5 minutes in length that will walk you through how to enter the data, how to submit a chart, how to close out a cycle when you've entered all the required numbers. And then if you're interested in doing this by yourself, once you've completed data entry for a particular cycle, you can see how you're progressing towards the measure aims that we've set. So that'll be coming, and that'll be something separate that you can look at and pull up and reference at any time. So now our action items. We hope that you'll move forward and use a team learning environment for this project. So have a team meeting, Create and foster an engaged and powerful clinical setting that has a culture to support PMP. Host that team meeting, communicate the purposes of this project and what the aim is. And then as you have the members around the table, highlight each individual's skill set and have those in mind as we're progressing forward for upcoming activities. Talk about how long this project is going to happen, what roles and responsibilities will be, and how those will build upon pre-existing roles and skill sets, and what this will look like in terms of your office flow. Mention that office and process mapping is something that you'll be working on. So again, having everyone come to the table during that conversation will be helpful in making sure that this is a seamless journey. You'll then gather the baseline data that we just covered with that chart review tool, and then we can move forward into Module 2 and get some more of the specific content and resources for PM.